Good evening, Dr. Devendra. Shall we start?
Please, sir.
So, good evening, everyone. On behalf of Indian Society of Gastroenterology, I invite you all to the Global Association of Physicians of Indian Origin, the another session on gastroenterology. And today we have very important two lectures to be given by eminent persons in their respective field. As we all know, the metabolic associated steatotic liver disease is on rise. We do see fatty liver quite often in our day-to-day clinical practice, also in IPD patients. So, weight loss is the only option for treatment of these MASLD patients, and we do have many options for getting the weight loss, but it is very difficult to maintain the weight loss. So first, we'll discuss how endoscopies can help in reducing the weight in these group of patients or any other patient who is obese. The second thing is, since IBD is also on rise, we all are aware that inflammatory bowel disease is increasing in our country day by day, and we are getting more and more patients in our OPD also. The most important thing in inflammatory bowel disease these days is the time taken from onset of symptom and the diagnosis of the disease. This is the most important point. So if the physicians know the symptoms of the disease early, if they could recognize the symptoms which could be of IBD early in the course of illness, they can refer the patient to appropriate person, get it diagnosed early, and the early diagnosis it will definitely change the course of the disease. So with this background, I invite the chairperson of today's meeting, Professor Amit Mathur. He is ex-professor of gastroenterology at SMS Medical College. Currently, he is senior consultant at Mangalam Hospital and Super Specialty Hospital at Jaipur. Uh, he has published a lot in the field of gastroenterology and hepatology, and he has also received Young Investigator Award from Indian Society of Gastroenterology in 2020. And he has many interests specifically in the endoscopy, in the bowel diseases, and also in the dyspepsia. So, Professor Amit Mathur will chair the session and he will invite the speakers. Professor Amit Mathur, please.
Thank you, Dr. Dadhich, for this wonderful introduction. And without wasting any time, we would move on to the first very interesting topic of metabolic endoscopy. And we have eminent speakers with us. The first speaker is Dr. Sunil Mathai, and he is presently working as a consultant in the Department of Gastroenterology Medical Trust at has published over 70 research papers in various Indian and international journals, and his area of interest are therapeutic endoscopy and endosonography and poems, and he's been doing third space endoscopy, and he has a keen interest in teaching and training. So over to Dr. Sunil Mathai for his talk on the interesting topic of metabolic endoscopy.
Thank you, Dr. Amit. Am I visible and my slides are they visible to everybody?
Yeah, I think we can see them.
Yeah, okay. Fine. So metabolic endoscopy is something which is a new thing, probably a decade old. People have been practicing bariatric surgery. I'm sure that bariatric surgery has been around for 20-30 years now. So endoscopically, if you try to combat obesity, we have a lot to do there. We can deal with the stomach, we can deal with the small intestine, we can deal directly with the patient's hormonal changes in the body. So metabolic endoscopy has taken up in a big way all around the world. So let us have a bird's eye view into this, because this is a basics for physicians. So I'm not going into the depth of metabolic endoscopy. So let us have the first slide. Can you see the first slide? The magnitude of the problem. Am I visible? Hello?
Yes, sir.
Okay. So if we are looking into the magnitude of the problem, 1 in 8 are obese. From 1990 onwards, the adult obesity has doubled and the adolescent obesity has quadrupled. It faces a lot of economic impact, social impact, and a lot of things which fall along with the development of obesity. So let us see what actually happens in obesity. See here, what you're finding is the calorie intake of a patient chronically exceeds the net requirements of a patient. So when a calorie intake chronically exceeds, the body adapts to it. The body has got something called a physiological adaptation. Now, how does it adapt? One way of adapting is it alters its gut hormone secretion. Now, there are two types of gut hormones. You can find one hormone is the orexigenic hormone, which induces eating, which induces appetite, called the ghrelin. And the other one is the anorexigenic hormone, the GLP-1 and the peptide YY, which induces anorexia or satiety. Now, an imbalance will definitely lead. If the ghrelin is more, you tend to eat more and you tend to grow fat. So this physiological adaptation will occur when the calorie intake is chronically exceeded. Now, what happens to the adipose tissue? The adipose tissue function, you find there is an increase in fat mass, and this increase will lead to an oxidative stress within the adipocytes. So what it results in is the development of a pro-inflammatory state. A continuous low-grade inflammation is set in the adipose tissue. Now see what happens to insulin. See, high circulating blood glucose levels will lead to high insulin response. Now, when high insulin response happens every day, in the peripheral tissues, the insulin resistance will set up. Insulin resistance will lead to, again, secretion of more insulin. And finally, the insulin resistance will land up in type 2 diabetes and cardiovascular disease. And the high insulin response, if it is chronically lasting, it will finally exhaust the beta cells, leading to beta cell failure and need for exogenous insulin. Now look at obesity. What all things it brings to you? Your quality of life is lost. You tend to develop type 2 diabetes. You tend to develop mental health problems because of obesity. You don't have the confidence to face others and go into society. You have reduced mobility due to the weight. You have back pain and osteoarthritis in the long term. There is an increased cancer risk. We get shortness of breath and obstructive sleep apnea, and of course, cardiovascular disease. So all the systems are involved here in obesity. Now, this is the economic impact as well as the social impact we have with obesity on the quality of life. Now, how are we going to fight this? Now, to fight this, we have to definitely think about one, restriction of calorie diet. Now, is it effective? The diets, are they effective? Now, a short-term weight loss can be achieved by these calorie restricted diets. What they bring about is, when you restrict calories, your orexigenic hormones, that is, that hormones which want you to eat, that will go up. The ghrelins will go up. And finally, a calorie restricted diet after a short-term weight loss will end up with a rebound weight. So this has led to failures in a calorie restricted diet. Now, what about pharmacologically derived gut hormones? The market is bombarded with them: semaglutide, liraglutide, as well as the latest one, tirzepatide, which is the Mounjaro. So a lot of pharmacologically derived gut hormones, which are agonists or antagonists, that replicate the changes observed following bariatric surgery. So we are trying to do it the shortcut, but that doesn't work, because in the West, after the introduction of semaglutide, a rebound weight gain is a problem now. So you can't take it lifelong. It's very expensive. So that is also not a permanent option. Of course, then the third option, the bariatric surgery, it is durable. There's no doubt. 30 years of bariatric surgery, we know it is durable. But there are certain other things like anti-diabetic effect, which is not related to the weight, because bariatric surgery brings about a release of anorexigenic hormones that improve whole body insulin sensitivity, improves diabetes. So independent of the weight, there are other good things about bariatric surgery. Now, the endoluminal procedures. This is what is the topic today. The endoluminal procedures, we are trying to mimic whatever the bariatrician is trying to do inside. So let us have a look into that. So we have gastric volume restriction. That is the first thing we are planning to do, the gastric volume restriction. So make sure the patient is eating less. So how do you do it? So one of them is the earliest one was an intragastric balloon. Just put a balloon into the stomach. Now, what does this balloon do? This balloon effectively takes up a major volume of the stomach. And what you're finding here, if you look into this balloon with so much of volume being occupied, the patient tends to eat less. And because of that fullness of satiety, the ghrelin hormones also come down. So there is a hormonal effect plus the effect of volume restriction. But the problem here is you can't keep it for long. The balloons have to be taken out after 6 months to 1 year. Again, we have a rebound weight gain. Apart from that, the balloon sometimes produces ulceration in the stomach mucosa. It produces obstruction. It can produce bleeding. So there are some adverse effects also associated with the balloon. Now let us see the Tarpon Springs criteria for the ideal gastric balloon. They lay down that smooth surface, a durable material. You should fill it with liquid. Radiopaque marker should be there, an adjustable size so that you can adjust to different persons. This was the Tarpon Springs criteria for the ideal intragastric balloon. This was laid down in 1987. And after that, we have had a lot of balloons. Now see the number of balloons we have. We have the Orbera, which is fluid-filled balloon. We have the Spats, which is again a fluid-filled balloon, but it is readjustable. So you can increase from 500 to 700 after some time. The Ellipse, which is a fluid-filled balloon, which is inserted by swallowing, it is biodegradable. So after 4 months, it just leaves your body. It passes out through the small bowel. The Heliosphere, which is an air-filled balloon. The Obelon, which is an air-filled balloon. The Reshaped Duo, again, which is a fluid-filled balloon. Now, all the trials which have been done on these balloons, just see how much of weight loss it has induced. From 13.4, the lowest was 7.1, from 7.1 for Obelon to 15 for Spats. So we get to the tune of somewhere between 10 to 15 is the average weight loss achieved with an Orbera balloon. So it is used for people who have an obesity BMI of somewhere between 28 to 35. Now, the endoscopic sleeve gastroplasty. This is a 10-year-old treatment which has just evolved for the past decade, standardized right now. And what is being done is, you see the anterior wall and the posterior wall of the stomach. They are being marked. And they are sutured with an endoscopic suturing device. See that? It is an endoscopic suturing device which goes in and sutures the anterior and the posterior walls. And when you pull that sutures, the anterior and the posterior wall gets opposed to each other. So at least we can get a reduction in volume of approximately 60 to 70%. See that? So this volume reduction, if you look into it, how does it work? Now here you can see this is the suturing area which is being sutured as a body. The fundus is spared. So how it does that? The stomach accommodation is there in the fundus and a delayed gastric emptying occurs. Once the accommodation happens in the fundus, they feel satiated. So they don't want to eat more. So delayed gastric emptying and early satiety is a mechanism where endoscopic sleeve gastroplasty works apart from gastric volume restriction. Now, this has been found to be quite effective in weight loss. Now, similar to that, from different parts of the world, plication methods have evolved. One of them is this primary obesity surgery endoluminal. Again, a different methodology where you clasp or grasp the mucosa, create folds, and plicate the insides. So it is virtually similar done in a different way. Finally, it is all reduction in the volume by plication. The Pose 1 was the older one. We have the Pose 2 now, which grabs more tissue and plicates more in the stomach. Now we have something called endomina also, which is another plication device. They all come from different parts of Europe, the Spain, the Netherlands. So you see the endomina, what again it does is, in a different way it plicates. So it goes in, helix the tissue in, and they do a plication. They do one of the sutures in one area, does another suture in another area. So different ways of suturing is there, different ways of technology development. And when you pull the thread, the apposition of the mucosa comes in and you get a final figure like this. So the stomach volume is reduced. The endosip, this is a more automated kind of stuff. It has not been commercialized yet. But what you see is here, there is no operator dependence. There is a motorized kind of suturing where the entire stomach is plicated from one end to the other. So it's like a sip. So it's called an endosip. So these things are evolving. I mean, technology is really bustling around this endobariatrics because that is an epidemic beyond proportions. Now see what has happened to gastric remodeling. We have the ESG, the Pose 2, 1, and the endomina. The trials which have evolved around this are depicted here. One of them, the Merit trial, which got published in 2022 Lancet, shows that Apollo endosurgery, the endoscopic sleeve gastroplasty, has been able to achieve 13.5% sustained weight loss. The importance is sustained. Compared to the balloon or the pharmacology, these are sustained weight loss. So this has been seen replicated in Pose as well as endomina. Now the small intestinal interventions. Small intestinal interventions target more towards hormonal or signaling pathways. So we can also, in fact, do some bypass small intestinal interventions. So let us have a peep into that. See this, duodenal resurfacing. Why this happened, this idea happened is, in diabetes, the duodenum is a major area where a lot of hormonal interactions happen into the body. So it's a micro environment by itself. So what happens in diabetes patients, they have done a lot of studies on the duodenal mucosa. They have found that the mucosa has got a low inflammatory state existing there. So when there is a low inflammatory state existing, the signaling pathways are lost, the feedback mechanisms are lost, the hormonal releases are being hampered. So what you get eventually is fatty liver or diabetes. Suppose you are able to ablate this mucosa, and if they regenerate, a new mucosa comes up, maybe this can be corrected. This was the idea. So what they did is, duodenal resurfacing has been done first with argon plasma coagulation, then with different thermal things, then with electroporation. So one of the major things which have come up is this Revita. This is a methodology whereby saline is injected into the mucosa to raise the mucosa, and the raised mucosa is being ablated. So you can see it is being ablated once the saline is injected. Yeah, and this arm actually ablates. So it does an injection and ablation. So it keeps on doing it for about 9 to 10 centimeters. And what it leaves us is an ablated mucosa which regenerates in 3 months, and a lot of reversal has happened to diabetes type 2. Now, a duodenal bypass sleeve. So if the duodenum is a major problem, why not bypass it? So one of the ways of bypassing is put in a large, long 60 centimeter sleeve into this. So this is how it is done. This is called endobarrier. So a large sleeve is being placed. So you can see it is all done under fluoroscopic guidance as well as endoscopic guidance. And once it is in place, what normally happens is we have to anchor the proximal end, otherwise it will migrate off. Now, how to anchor it? There is a deployment here. Once a deployment of a stent-like end, a deployment flange, which can be sutured here. And then when you do the dye study, you see that nothing goes into the duodenum. So you're bypassing the entire duodenum. So this endobarrier has also been found to improve diabetes, and in metabolic endoscopy is one of the major things which is under trial. Now this is a novelty, the magnetic enteroenteral bypass. So this has been something where two endoscopies are required. So one goes from the upper end and another one goes from the lower end. So this is a magnet which comes through the endoscope. So what happens is when these two magnets get opposed, you see that. So they form a union and the inside mucosa gets necrosed off without any, it's a clean necrosis, without any perforation. And the magnets then pass off. So this anastomosis will give a direct jejunal-ileal bypass where weight loss is a target along with improvement of HbA1c or fatty liver. So see the results of this. The duodenal mucosal resurfacing, which has brought an HbA1c loss of approximately 10.4 to 6.6 millimoles. You see the bypass liners, they also have similar kind of HbA1c improvement. The incisionless anastomotic system or the magnetic systems, they've also produced the same thing. So they are all effective, but they are yet to be commercialized and is not available in India at present. But we have the endoscopic suturing, we have the magnets are available, but right now they are placed with the control of laparoscopy. Now see another one, the transpyloric shuttle, where this will produce an obstruction. This balloon area will produce an obstruction here in the antrum, producing intermittent kind of obstruction. It doesn't produce vomiting, but this will reduce or delay the gastric emptying and produce a weight loss. So satiety is brought out. Now this is a bit of a cruel system, I would say, the Aspire system, where you eat. If you want to binge eat, you can eat, but everything is aspirated out through a peg tube. So once you do that, the patients tend to lose weight naturally. But then Aspire has not been accepted worldwide. Anyway, weight loss has been brought about by both these mechanisms. Now, endoscopy has also got something called revisional endosuturing. Revisional endosuturing is you do a gastric bypass and then you find that after the bypass, the stoma is becoming very wide, dilated. Again, another surgery is not possible because already a big surgery has been done. So with the endoscope, you just suture that stoma and make it smaller. So this is revisional endosuturing, which has been definitely found to be useful in reducing weight once a regain occurs after the gastric bypass. So this is the studies of revisional GJ. You still get a total body weight loss. See that of 7.5 to 3.5. Again, you get a weight loss after doing that Torre procedure. That is the outlet reduction procedure. So to summarize, I think I've shown you what I've shown you is just a bird's eye view of all the procedures we do endoscopically and term it as metabolic endoscopy. This is on the up. So minimally invasive metabolic endoscopic interventions are the way forward because a lot of technology, a lot of money is being pumped into it to make it minimally invasive. As well as the numbers also are increasing of obesity. Presently, they achieve 15 to 18% sustained weight loss over 1 to 5 years. They may be combined with pharmacology in the future for sustained effect, and the maximum utility is in the BMI range of 30 to 40, class 2 obesity. So thank you very much for your patient listening. We'll answer the questions probably after the session.
Dr. Sunil?
Yeah, please tell me.
Dr. Sunil, Dadhich, sir.
Are we taking the questions now?
Yeah.
Do we have some questions from the audience? We can take it up now.
Yeah, sure, no problem.
Dr. Dadhich?
Dr. Amit, I think let's have the second talk, then we can have the combined session.
Okay, perfect. So,
What do you think?
I cannot hear your questions, but there is some disturbance here. Is somebody talking?
can you hear us now?
No, I can't. I didn't hear the questions anyway.
We are planning to take the questions at the end of the session.
Oh, great. Fine. Then I'll stop sharing my slides. Yeah.
Perfect. So we move on to the second topic of inflammatory bowel disease, and Dr. Devendra Desai, who's currently working as a consultant gastroenterologist at PD Hinduja National Hospital, Mumbai. He would be delivering this lecture on inflammatory bowel disease. He has more than about 200 publications, and his research interest is IBD and AI. So over to Dr. Devendra Desai without wasting any time.
So let me first check whether my slides are coming.
Perfect.
Just 1 minute. I have sent my slides to GAPIO mail in case this doesn't work.
Can someone from the technical team help him out?
Sir, I am just downloading the slides, sir. I'll share if it doesn't work, sir.
Yeah, the videos
Great.
will not come, but I think sorry. One minute. Can you see my slides?
Not yet.
Huh? Not yet. Okay.
So can you see it now? I have shared from here.
Yes, I can see.
So just let me know when to pass the slide.
Okay, no problem. So I'm sorry for this uh, problem, but okay. So I wish to thank ISG and GAPIO Delhi, and I'm going to speak on ulcerative colitis, what the physician should know. Next slide, please. So, why bother about ulcerative colitis on Saturday morning when you can watch IPL or so rather than attending webinar like this? Next slide, please. So, why? Because I would like to show you the trend from Hinduja Hospital IBD registry data. And you can see that from 2000 to 2009, going to 2024 end, you can see that total number of IBD patients has increased by 8 times. Ulcerative colitis has increased by 5 times, and Crohn's disease has increased by a phenomenal 46 times. Now, I can accept that there is some bias of referral center, but it's just that this is the data from one center, and if we combine data from all over India, we will have huge numbers. All the centers are reporting increasing number of IBD patients, and all of us are likely to see IBD patients, whether physicians, surgeons, other branches, and some will be complicated or progress if not treated in time. Next slide, please. So the point I would like to emphasize here is a delay in diagnosis of IBD in clinical practice. And you can see that this is a systematic review of 31 articles, and the delay in ulcerative colitis was 2 to 6 months, and the delay in Crohn's disease was 2 to 12 months. So when we combine preclinical stage and diagnostic delay, we have complicated disease in Crohn's disease and weight loss and anemia in patients with ulcerative colitis at diagnosis. Now just one slide back. No, next. Yeah. So let us look at this real life scenario. This is a 40-year-old gentleman who presented with abdominal pain and diarrhea for 2 days. He improved after symptomatic treatment from a family physician. However, there was recurrence of symptoms after 15 days. He was treated with one more course of antibiotic. Again, after a month, he had diarrhea with blood in stool, and he was referred to surgeon and diagnosed as hemorrhoids and treated. Next slide. After 2 months, again the symptoms recurred and he was reviewed by the surgeon and he underwent hemorrhoidectomy. And afterward, he was well for a month and symptoms then recurred. So by the time he was seen by a gastroenterologist, he had received 3 to 4 courses of antibiotics. He had undergone surgery and there was a delay in diagnosis of 4 months. So he was advised workup. Next slide. So hemoglobin was 11.5, ESR and C-reactive proteins were elevated. The stool showed lot of pus cells and RBCs. The stool culture showed E. coli, which is commensal. Stool calprotectin was more than 1800 micrograms per gram. The stool for Clostridium difficile toxin was negative, and as patient had received multiple antibiotics, and based on these findings, he was advised colonoscopy. Next slide, please. So on the left, you can see that there is a normal colon, which is basically a pink, and you can see the normal vascular pattern. On the right, you can see that there is a loss of vascular pattern and superficial ulcers. Next slide, please. You can see this here. I'm happy video is playing. Okay, next slide, please. So the colonoscopy was suggestive of ulcerative colitis, and the biopsy showed basal plasmacytosis, cryptitis, and crypt abscesses. So all these findings suggest the diagnosis of ulcerative colitis. Next slide, please. So the points which suggest the diagnosis of ulcerative colitis in this patient is history of diarrhea with blood and mucus in the stool, the stool abnormality, which consisted of pus cells and RBCs, and there were no parasite in stool on stool examination. Culture showed no infection. Stool was negative for Clostridium difficile toxin assay, and HIV was negative. The positive features include elevated ESR and C-reactive protein. Colonoscopy showed continuous inflammation, and biopsy was supportive of diagnosis. Next slide, please. So what do we do in children where colonoscopy is little difficult and not a priority? We ask for ESR and C-reactive protein, stool routine, and stool calprotectin. If stool calprotectin is high, then we further investigate. I would like to say a little bit about stool calprotectin. This is a marker of intestinal inflammation. It is a protein released by neutrophils. The normal value is up to 50 micrograms per gram of stool, and it can be elevated in acute infection, but usually not so high. If it is very high, more than 1800, that is suggestive of IBD, and we need to investigate further. It is useful as non-invasive markers in children as well as adult. And as I mentioned, if elevated, colonoscopy may be planned. However, it is an expensive test and costs more than 3,200. But it is cheaper than colonoscopy. So now we have diagnosed ulcerative colitis. What further information is needed? We need to know the extent and severity of inflammation. So as we can see here, the only rectal involvement is proctitis, rectum plus sigmoid, proctosigmoiditis. The left-sided, if all left-sided, this is left-sided colitis, and anything proximal to splenic flexure is pancolitis. And as we know, in ulcerative colitis, there is only mucosal involvement. Next slide, please. So now we have known the extent. What about severity of ulcerative colitis? So we have clinical as well as endoscopic parameters, and the clinical commonly used score is Trulov's and Witt score. And in this, the mild ulcerative colitis is when there is less than 4 bloody stools per day. Moderate if there are 4 to 6.
The slides are not moving,
And, no, no, now can I?
Are they visible on the screen? Because we...
Okay.
Is it moving, sir?
No, not yet.
For me, it is moving.
Can you check it now, sir? Now is it?
Yeah, they are moving.
Okay. So a severe ulcerative colitis is when there are more than 6 stools per day with evidence of systemic toxicity such as fever, tachycardia, elevated ESR, and C-reactive protein. Next, please. So endoscopic severity, that video I have deleted because it was becoming too big a file for transfer or by email. So we have two scores, Mayo endoscopic score and ulcerative colitis index of endoscopic index of severity. So we take into account both clinical and endoscopic severity while starting the treatment. Next slide, please. So let us come to the management of ulcerative colitis. This is medical in majority, and surgery is required over a long period of time only in 15 to 20% of the patients. Next slide, please. So the principles of treatment are to induce remission, to maintain the remission without steroid, and achieve mucosal healing, which is associated with reduced long-term complications. Next slide, please. So the medical management consists of the main drugs are salicylates, steroid, and immunosuppression. So there are next line of treatment biologic agents such as anti-TNF agent, which are infliximab and adalimumab, anti-integrin molecule, which is vedolizumab, and anti-IL-12/23, which is ustekinumab. The newer drug is JAK2 inhibitor, which is an oral drug, and at the moment tofacitinib is available. So we should not forget that more than 50% of the patients use complementary and alternative medicine, and many don't tell us. Next slide. So this is the treatment algorithm of induction and maintenance of remission in ulcerative colitis. If you look at the left, In mild ulcerative colitis, we use 5-ASA, which has 40 to 80% response in 4 weeks. And if required, we can add topical ASA. When we come to moderate ulcerative colitis, in addition to 5-ASA, before oral steroid, now we have budesonide MMX, which is useful, and it is a gap between 5-ASA and oral steroid. When we look at the severe ulcerative colitis, we have uh, these patients who don't respond to oral steroid, we have azathioprine or 6-MP. And if the patient does not respond, then we have biologic like infliximab, adalimumab, tofacitinib, vedolizumab, and ustekinumab. If the patient, in spite of this drug, is not responding, then we have elective colectomy. In acute severe ulcerative colitis, the patient has to be admitted. The first step is to give IV steroid, and if the patient does not respond to IV steroid, then we have salvage treatment. Earlier, we have infliximab and cyclosporin, IV cyclosporin A, but now there are some studies which are suggesting that tofacitinib can be used. And if the salvage therapy fails, then we have emergency colectomy. Next slide, please. So one important thing that I would like to stress is topical therapy in ulcerative colitis. This consists of enema, suppository, and foam. So it is effective in left-sided as well as extensive ulcerative colitis, but it is grossly underused. Now for rectum, the suppositories reach upper rectum, that means 15 to 20 centimeter beyond the anal verge. The foam is used, it reaches up to sigmoid colon, and liquid enemas reach up to splenic flexure. Next slide, please. So now if we have achieved the induction, we have maintenance therapy for ulcerative colitis. And the most important point here is that we have to maintain without steroids. So as I mentioned, salicylates, immunosuppressants, biologic agents, JAK2 inhibitor, they all are useful for maintenance therapy with ulcerative colitis, and we should use the agent with which we have achieved induction. The same agent can be used for maintenance also. Next slide, please. So many times our patient asks the question, how long should be the treatment? So the treatment is lifelong. However, in selective patient, treatment may be discontinued after extensive evaluation. Next slide, please. So every patient asks about diet, including IBD patients. So till recently, there was no diet such as IBD diet. But recently in 2024, American Gastroenterology Association has issued dietary advice, and it says that all patients should be advised Mediterranean diet. And Mediterranean diet basically is rich in a variety of fresh foods and vegetables, monounsaturated fat, complex complex carbohydrates, and lean protein. And the diet should be low in ultra processed food, added sugar and salt. Next slide, please. So patients with IBD, ulcerative colitis or Crohn's disease, have various extraintestinal manifestation. So on the left top, you are seeing the episcleritis. Then we have erythema nodosum, pyoderma gangrenosum, which can start as a small wound and increase, aphthous ulcers, and arthritis, right knee arthritis in this patient. Next slide, please. So let us look at quickly at complications. Next slide, please. So this patient presented at 2 a.m. with abdominal pain. She was fortunately admitted. A awake resident actually took an X-ray abdomen, and this showed the air under the diaphragm, suggestive of colonic perforation. Next slide, please. So patients can have massive bleeding. Next slide, please. So toxic megacolon, so it basically is massive colonic dilatation, and if the right colon diameter is more than 6.5, it is a toxic megacolon, which is an emergency. Next slide, please. Next, next, next. Okay, if you can play this. So this is a patient who had 13 years of ulcerative colitis, and she came. So she was going somewhere out of Bombay, and we suggested her surveillance. And you can see that in cecum there is a plaque-line lesion. We took biopsy, and at hepatic flexure you can see that there is second polypoidal lesion. The biopsy from both showed adenocarcinoma, and the patient was operated. Next slide, please. Next, next. Huh. So the surveillance for colorectal cancer is generally advised after 8 years of disease, and there should be colonoscopy every 2 to 3 years with biopsies. We can divide them into high risk and low risk and decide the interval of surveillance. In our data, 2.8% patients develop colorectal cancer. Next slide, please. So in the long-term follow-up, we need to ensure the compliance, as in one of our study 80% of the patient tend to miss the medication, and there are often neglected issues such as anemia, malnutrition, bone disease and sarcopenia, anxiety and depression, and the vaccination schedule. So these are often neglected area, and we can actually together, physician as well as gastroenterologist, look at these issues more closely. Next, please. So patient education and support groups are important, and the support groups play a vital role in patient and family education and treatment continuation. So there are multiple groups in India who are doing very good work. One of our association is Colitis Association of India, which we started in 2005, and we have completed 20 years now. Next slide, please. So there are a lot of changes happening all over. So you can see that the party symbols have closed, has changed. The Allahabad has become Prayagraj. So similarly, there are changes happening in IBD also. Next slide, please. So the disease characteristic is changing, and we see more severe disease. Then we have increasing proportions of extremes of age, like 20% of the patients are younger and 17% of the patients are elderly, more than 60 years. So about 40% of our patients form this group, which is important, and most of these studies don't include them. So it's important to cater to these patients also. Next slide, please. So also, now we have single dose formulations available, and previously we used to give mesalamine thrice a day. Now we have therapeutic drug monitoring for thiopurines and biologic, and the therapeutic drug monitoring can reduce side effects, improve efficacy, and save cost. Next slide, please. So in summary, dear friends, IBD is increasing in India. There is a changing scenario that we see more severe disease, more occurrence in extremes of age. Delay in diagnosis is very common. The principles of treatment include induction of remission, maintenance of remission, and mucosal healing. 5-ASA, immunosuppression, and biologic drug are the mainstay of treatment. The topical therapy is underused, and we should restrict steroids to only short-term use. The surgery forms important treatment, especially when there is emergency, and surgeons should not be informed late. And now we have guidelines on diet. Thank you. Next slide. So thank you very much, and sorry for this technical glitch.
So, Dr. Dadhich, can we take up a few questions?
Yes, I think we can start now Q&A. So since there are no questions in the chat box right now, so may I ask the first question to Dr. Sunil Mathai? Dr. Sunil, can you hear me?
Yeah, I can hear you.
So you have shown various techniques of doing the endoscopic ways and means of doing bariatric or metabolic procedures. So do we have any particular indication for a particular technique, or it depends upon the choice of the endoscopist who is doing it?